Okay, so I'd just like to welcome everyone to our live stream today. Today is World Mental Health Day, and from Your Health, Your Life, we have Dr. Naeem Dalal to help us discuss the topic of today. Today, we're going to be discussing suicide. And among some things that we'll be talking about with suicide are going to include why some people get to do it, and essentially how we can help along the way. So for anyone that's joining us either on Zoom or YouTube, please feel free to leave your questions in the box so that Dr. Dalal can answer them. So I think just to open the floor, would like Dr. Dalal to introduce himself to the audience so that people may know who they're talking to and how just awesome this event is going to be. Dr. Dalal.
Hello, everyone, and a warm World Mental Health Day to you all. Hello, everyone, and a warm World Mental Health Day to you all. My name is Naeem Dalal. I'm a psychiatrist registrar at the university teaching hospitals in Lusaka, Zambia. I am a mental health expert, and I work in the field of mental health. I'm very grateful to be here and humbled to be invited and looking forward to interacting with you all.
Well, thank you very much, Dr. Dalal. We're very happy to have you on Your Health, Your Life, and we hope that we're going to have a fruitful conversation on suicide and some of the things that may contribute to people having it or not. So like we mentioned, the course of our discussion is going to outline the following questions. What is suicide? What are the common triggers for suicide? Is there an interplay of your genetics, your environment, as well as your social aspect that may predispose you or that may predispose someone to having suicidal ideation or suicidal thoughts? That's something important that we have to establish so that people may know. Also, how then can we as a general populace help in bringing an end to suicide? Because we've seen a number of people that are coming in the hospitals, killing themselves or trying to kill themselves. So we're going to see how we also as a community, as a population can help with people that may be having suicidal ideations. After that, we're going to take a couple of questions from the audience. If you have a question, please do leave it in the comment section on YouTube, or if you are signed in with us on Zoom, please do leave the question for us in the comment section in the chat. So I think just to get the ball rolling, Dr. Dalal, kindly explain to us what suicide is. It may seem simple, but let's hear it from the expert's opinion. What is suicide?
Yes, suicide, also known as self-harm, is one of the leading causes of death in the youth. So when I say youth, I mean the age ranges from adolescence, which is 14, 15, going up to the ages of your late 20s, and in some countries, early 30s. So suicide is when people harm themselves with the goal of ending their life, and they may die as a result. Now I say they may because oftentimes self-harm attempts may not go into completion, and this does not attempt into loss of life. One thing that people need to understand is suicide can be either active or passive. Passive suicide is where individuals have thoughts of not wanting to live. I'll repeat that. Passive suicide is where individuals have recurrent thoughts of not wanting to live, but they do not act on them. So this could be an individual who says, I'm tired of life, I can't go on like this, I wish or I hope or I just want to end it all. However, they don't have the energy or the zeal to actually go ahead and act on that thought. So that's passive suicide. And then we have active suicide, where these are individuals who do have the thoughts of not wanting to live, and they actually invest their time, their energy, and their efforts to muster the zeal to go ahead and carry the act out of suicide. And they may go on to die as a result. So this is what suicide is. And then we also like to define what a suicide attempt is. And this is when people harm themselves with the goal of ending their life, but they do not die. So this is often where in accidents and emergency in the hospital situation, we get attempted suicide or a para-suicide case where we often say that, okay, this is an individual who tried to take their own lives, but it was not successful. So off the bat, I would like to mention, Teddy, that let's avoid using terms such as committing suicide, as we discussed, and let's avoid using the terms such as successful suicide or failed suicide when referring to suicide and suicide attempts, as these terms often carry negative meanings. And also, let's use words such as died by suicide to relay the message that death by suicide is also equally a death. And I would like to make mention from the start, as we're defining and just laying the groundwork about suicide, that it's not a crime. So if a person does have those thoughts, they can reach out for help and they will get the help. They will not be taken accountable for that. And also, should they find themselves in the hospital, yes, it is a notifiable case to the law, but that does not mean that they will be taken in and committed for it. So we avoid using the word now committed suicide, but rather we say carried the act of self-harm out. Yes.
Oh, that's a lot of insight in those statements. So committed suicide is not a good thing to say. Death by suicide is acceptable. And it's a bit interesting because most of us tend to think that suicide in itself is a crime. And I think this is what makes most people to not come out when they may be having what you're describing as passive suicide, where they're having these thoughts of trying to kill themselves, but because they think it's a taboo, it's unacceptable, they may get arrested, because there have been people that have been detained because of attempted suicide. So maybe you can just elaborate more on that so that everybody gets this. Is suicide a crime?
So suicide is not a crime. Having thoughts of not wanting to live is not a crime. Hurting yourself, if you're feeling overwhelmed, is not a crime, provided you come for services. And this is one thing that you need to know. And we also have a Mental Health Act now, and the Suicide Act that was actually abolished a long time ago. So the Mental Health Act in Zambia, as of 2019, looks at self-harm attempts or risk to oneself. We often like to refer in mental health and well-being, simply states that you can reach out for help and you will be given the help. Now, the fact remains that you are at risk to yourself should you have thoughts of not wanting to leave. And because of that, for your own safety and for the safety of people around you, it is notifiable to the law. But that does not mean that it is being notified because you are being committed, but rather it is being notified because we want to make sure that you are supported and caregivers or care providers within your network or within your circle are being identified as well. So to everyone out there who is having thoughts of not wanting to leave or have had attempts of self-harm and worried to reach out for help because they're worried that they may be committed, please, 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 please note that that is not the case.
Wow, thank you. Thank you very much for that. I too have learned a lot about this, about some of the perceptions that we may be having as a health practitioner. It's an eye-opener as well. Death by suicide, committed suicide. I think that's a very big paradigm shift as much as I can think. So thank you very much, Dr. Dalal, for highlighting that. So what would drive a person to reach in that point? What would drive this individual, this human being, to reach a point where they would start having suicidal thoughts, where they may reach a point of passive suicide? And then how do they get to the point of active suicide itself? What things can take them there?
Okay, so Teddy, we're living in a society, and I always like starting from the very beginning, where we define health. We say that health is a complete state of physical, mental, and social well-being, and not just the absence of disease. So when you look at that definition, we look at it from a physical perspective, then we look at it from a mental perspective, and then we look at it as a social perspective. And again, when you look at the mental and social perspective, we look at health from a view of how we live in a society and a community. So now, where does the idea of suicide come from? Well, we look at it from the biopsychosocial model. Now, this is another concept that I'm going to simply introduce because I feel it really helps people understand. So, biology is your physical self, which is your brain health in this state. So now, what does the brain entail? This also entails genetics and inheritance and familial patterns. So your mental well-being is actually one non-communicable disease that is equally inherited and passed on from generation to generation. Majority of chronic mental health conditions are actually known now that they are actually inherited. So that's one part that you need to understand. Then we look at the psychology. Psychology is where these are learned behaviors, thought processes, or solutions that we think of that we learn throughout our lives. It's not one thing that just happens today, but it's something that you've grown up, learned behavior from your community and your surroundings. So these are thought processes that we live through in our lives. So let's talk about thoughts of not wanting to live or communication about suicide. This is something that growing up we were all told that it's a taboo, it's something that you don't talk about, it's a sin. So that's another concept that people need to understand. Then we talk about society. This is culture, this is beliefs, this is education system, and it's how we are supported. So now when you look at all these three elements, the biopsychosocial model, you will come to realize that not everyone comes from well-to-do communities and upbringing and education and psychosocial support. At the same time, we have individuals who come from privileged backgrounds. These are individuals that are supported throughout, but then they equally may have a genetic predisposition to certain mental health conditions that can lead to suicide. So when we talk about suicide, it can be many things, and that can risk an individual to think about not wanting to live. Another thing that I would also like to mention about risk factors is that many people have this myth or misconception that suicide or self-harm is only in individuals who have an underlying mental health condition. And when I say mental health condition, I'm talking about mental illness because all of us have mental health. Mental health is a state of how we feel, how we think, and how we perceive our day-to-day life. But mental illness is where we have a disruption in how we see, how we feel, and how we perceive our day-to-day lives. And many people think that self-harm and suicide is equal to mental ill health, which is not true. Even people who have very strong mental health and well-being may have times when they have passive suicide, which is thoughts of not wanting to live because of the overwhelming nature in their day-to-day lives. So now, when you put all these things together, I would like to answer this to say who is at risk of suicide. I would like to say people of all genders, ages, ethnicities can be risked or be at risk of suicide. And the main risk factors that are known from research include family history of self-harm or suicide, chronic pain, chronic recurrent pain, um, mental health conditions such as major depressive disorder, as well as other mental health disorders such as substance use disorders. And in our country here in Zambia, alcohol use is very common, as well as other substances such as marijuana, which is cannabis, as well as cocaine and heroin. Then we also look at previous history of suicide attempts. We also look at exposure to trauma. It could be family violence, including physical or sexual abuse. And I make mention of this because of interpersonal violence and gender-based violence, which is rampant in our communities here. We can also talk about having recently been released from a toxic or traumatic environment. And for adults or juveniles who have been in prisons, these individuals can also be at risk of not wanting to live. And also, exposure directly or indirectly to other suicidal behaviors, such as that of family members or peers, or even influencers around in the community, such as celebrities as well. So these can be actual risk factors to individuals actually going ahead and carrying out the act of self-harm and actively being suicidal.
Dr. Dala, there's a tolerance to pain and endurance of difficult situations. One might experience a very difficult situation and come out of it unscathed. Then you may have another person going through something that person may think is small, minute, and insignificant. And that person, on the other hand, gets stressed to the point that they think of actually committing suicide, for lack of a better term, like we have mentioned. Those are terms we have to avoid. How do we put the two, how do we align them? Because the triggers themselves may be the same, but one person may come out standing tall, while the other may have thoughts of suicide. So what's your comment on that? Is there a line?
So, Teddy, there's no correct way of putting this to say, you know what, this is the prognosis and this is how it's going to act out. What you mentioned is based on an individual's lifestyle as well as the pattern of reality that they've lived. So if you're going to go by the concept that I shared earlier, the biopsychosocial model, let's give an example of a person called A and a person called B. A person called A has no genetic inheritance of any underlying mental health condition, and that person has had a very supportive family growing up and community growing up. But based on the socioeconomic environment, say, there's a lot of stressors, financial stressors, that person has probably been abused in one way or the other. That person may actually be at risk of not wanting to live. On the other hand, let's talk about a B who has a genetic inheritance of a mental illness. Maybe there's a family history of major depressive disorder in B. And then this person then goes through interpersonal violence growing up because of growing up in that family, or being abused similarly to A. Then what's going to happen is in B, that person's genes will actually be triggered and that person will further be at a higher risk. And this is where we also talk about concepts such as post-traumatic growth versus post-traumatic stress. Some people, due to their resilience patterns, can actually grow from trauma, whilst other people can actually feel more overwhelmed. And this is not something that we can just easily say that this person will go through it or this person will not go through it. So to answer your question, there's no straightforward way to predict or say this is exactly how it's going to happen, but we do know certain risks, as I highlighted earlier on, to say that stressful life events such as loss of loved one and interpersonal stresses such as shame, harassment may contribute to suicide risk, especially when they occur alongside with suicide risk factors, as I highlighted earlier.
Okay, no, thank you very much, Dr. Dalal, for that beautiful explanation. So maybe this can merge in as well, or maybe before we progress, it's something that we have to stress, that just because you went through something and you managed to go through it, it doesn't by extension mean somebody else has to endure the same situation the way you did. So if you think that somebody's reason for having suicidal thoughts is not justified, that shouldn't be the case, because people are different, like Dr. Dalal has mentioned, different experiences, different biology, and a different makeup. It all contributes to us having the strength to deal with certain situations. So maybe this is going to nicely fit in with the next question, where we want to look at how genetics interplays, how our social status or social cycles themselves are going to interplay. So maybe we can discuss them one by one. How does the genetic aspect itself contribute to someone having suicidal ideation? You mentioned earlier on about mental illness. How does mental illness make one more likely to have suicidal thoughts?
So our brain is the master organ of how we think, how we feel, how we hear, how we perceive our reality and our day-to-day lives. Now, I would like to make mention again here that, and the statistic that I shared to say, look, all genders, all ages, all ethnicities are at risk of, self-harm and suicide, active suicide. But it is also known that the second leading cause of death in the ages of 15 to 29 is by the death by suicide. And we need to understand that the brain is one organ that is still developing until its late 20s. So I'll repeat that. The brain is one organ that still molds itself and develops itself as far as the late 20s. And this is important to understand because there are mismatches in development at times in certain individuals' brains. And this is where mental illness comes about and mental health disorders come about. A very common neurotransmitter that we know that has been correlated to mood is that of known as the serotonin. Now, the serotonin is also otherwise known as the mood neurotransmitter, which is known to cause happiness or lead to peace and tranquility, so to speak. Now, in individuals who have major depressive disorder, the serotonin levels are low. What that means is that they don't have enough levels of serotonin for them to feel at peace or feel happy or feel the energy to go about their day-to-day lives. And because of that, these individuals often actually feel defeated or hopeless or feel excessive guilt or do not have the zeal to go about their day-to-day activities. And they don't do this for attention seeking, or they don't do it because they want to, but it's because actually, if you're going to do a functional MRI in these individuals, you'll actually see that the areas of the brain that utilize the serotonin neurotransmitter is actually low. And this is why they are feeling the way they're feeling. Now, there is a high correlation between certain mental health disorders and suicidal risk. Because these individuals are known to, die by suicide because of that underlying mental health condition. But again, I will echo that not all mental health conditions equals to suicide. So a few of the mental health conditions include conditions such as major depressive disorder, bipolar mood disorder, substance use disorders, post-traumatic stress disorder, severe generalized anxiety or anxiety disorder. So all of these disorders can actually predispose an individual to actually die by suicide. Also, another mental health condition known as schizophrenia. So all of these have to do with your brain. Now, again, with adolescents as well as youth, I would like to make mention that for them, suicide is not because they don't want to live, but more times, often it's because they want to distract from the emotional pain that they're feeling. So they carry out the act of self-harm. They do it because they want to release tension. They do it because they want to feel something. They carry out the act because they want to express themselves. And then they may also carry out that act because they want to self-punish. Now, these are all things that are happening in areas of emerging adulthood and trying to figure all these things out. And that is the critical period when the brain is developing. And as the brain is developing, the neurotransmitters are still forming. And because of that, individuals find themselves carrying the act out of suicide. So again, I reiterate, the brain still develops until its late 20s. And I would actually say that the part of the brain that is responsible for feeling emotions is often fully developed in the adolescence ages of 14 to 16. So a 15 or 16-year-old will be knowing that, oh, I'm happy, I'm sad, I'm angry, I'm anxious, I'm surprised. But they will not know how to act on that anger, surprise, happiness, because the part of the brain that is responsible for active decisions and executive decisions, which is the frontal lobe, is still yet to develop in the late mid 20s. So it's like there's a there's that connection that is yet to form, and those pathways are still forming. So to answer your question, it's not just the myth or the stereotype that we align with suicide to say it's attention-seeking behavior. No, not at all. It is actually brain health, and we now know better because of the breakthroughs in neuroscience.
Okay, that's interesting. So you've mentioned this neurotransmitter in the brain that sort of helps to regulate our mood and may in a way predispose us to having suicidal thoughts if it's deranged or if it's abnormal. And this can be caused by a number of diseases, brain diseases that you have mentioned. Are there any substances or chemicals that can cause a disruption in this chemical that can make someone predisposed to suicide?
So there are certain medications that can actually lead to reduced serotonin, but the jury is still out in terms of research. But it is known that chronic substance use can actually lead to what we call substance use disorders, such as substance-induced mania, substance-induced psychosis, or substance-induced mood disorders. And in these individuals, in the moment or in that particular moment, they may actually carry the act out of suicide as well. So that is something that we know. But as far as drugs and directly correlated to serotonin, the jury is still out, and we are yet to know more about that.
All right, thank you very much, Dr. Dalal. How does the environment that one is growing up in or that one dwells in, how can that predispose him to developing suicide? It may also obviously be related to the genetic aspect, but is there a direct relationship or a correlation with an environment for suicide?
Yes, so it is, as I mentioned earlier, that all ethnicities, all backgrounds, all socioeconomic environments are at risk of suicide. And this may have to do with the predisposition. So it is known that vulnerable communities are at the same amount of risk or even more as opposed to communities that come from high privileged backgrounds. But what I will actually say that both high socioeconomic environments, where we call them the people, the rich, the haves, and also the have-nots, the poor, the people coming from low socioeconomic environments, all of them are equally at risk of self-harm. And this has to do with because of the learned behavior. One of the key factors that has been known to correlate to suicide and suicidal thoughts and suicidal behaviors is that lack of support in the community, in the person's nuclear family or nuclear community, where they feel supported and where they can feel that they are in a safe space, because that actually promotes and acts as a protective factor against self-harm. And if that is absent, whether you're in a low socioeconomic environment or whether in a high socioeconomic environment, that actually can predispose you to thoughts of self-harm. Other than that, it is very well known that poverty, as well as all the things that come with poverty, poor financial background, actually leads to a lot of challenges. And this is because, you know, if you are in a low socioeconomic environment, then you have low privileges in terms of getting access to your basic rights, such as food, shelter, education. And all of these further hinders your psychology and also your community understanding of things. So with that said, it can also be a risk factor to not wanting to leave and giving up, or rather not just saying giving up, but rather not having the support structure to actually see another day. So with that said, socioeconomic environment and social environment has a very big role to play in self-harm.
Thank you very much, Dr. Dalal, for helping us to understand that. Another question that I would like to ask is, how then do we all play a part to prevent people from, how do we help people with suicidal ideations? Where do we start? If somebody comes to me and says, "Steady, I want to kill myself," where do I start?
So here's the thing. First of all, I'll actually start from a systemic point of view, then I'll actually come down to individual interpersonal point of view. We first need to learn and unlearn. So when I say learn and unlearn, I'll start with the unlearning. We come from very strong belief and cultural structures, and I'd like to first speak on religion, where most, if not all, religions actually say that suicide is a taboo, it's a sin, it's not something that should be entertained. But here's the thing, not to take away from religion, but actually talking about it from a perspective of prevention. If we're saying that suicide is a sin, then what is it that we're doing to prevent that sin? Because we should be doing something to prevent a sin. This is a question that I often ask religious elders and religious leaders, and I myself as a religious person, to say, what am I doing to actually help individuals not actually carry that act out? So now this is where we need to have open spaces and discuss ways to actually help people not wanting to leave to actually leave, as opposed to just shutting down the conversation by saying, wow, you're actually thinking about this, which means you're going to hell, or you're going to do something that will not be taken well in the religious spaces. So that's the unlearning that I talk about. Also cultural beliefs, to say suicide is just, you know, attention seeking, or suicide is just, you know, someone is mentally unwell and has a mental illness. This again has to be unlearned by individuals and societies and communities. And we need to understand that, you know what, it could also just be an emotional reaction. It would be an emotional storm that an individual is going through. And that is simply a question or a concern that they're not able to highlight. And they're simply saying, please help me. as I highlighted earlier on, to say, many people actually have the thought of suicide or actually carry the act out because they want to distract themselves from emotional pain, or they want to release tension, or they want to feel something, or they want to express themselves, or they self-punish. So how is it that we as society can actually release this kind of tension and support individuals? So again, we have to unlearn. Then as a society, we need to put protective factors. I will ask everyone to say, okay, if you have thoughts of not wanting to leave, or you've actually carried the act out, how many people know where to go for help? How many people know where to find Dr. Dalal or mental health professionals in their communities? Or if not, are there even mental health professionals in your communities? So again, that is something that society needs to build upon and learn. The fourth thing is about stigma that comes with suicide and what society needs to do. And I speak very strongly about this because when a person dies by suicide, we just sort of just put them in a box, and we just say, look, this is not something we're going to discuss because it's shunned upon. But then here's the thing: for every one suicide, 25 other people are actually thinking about it. So if there's one active suicide that's carried out right now, there are 25 people in that social circle or network that are directly going to be affected and going to think about carrying the same act out. So that means we are going to equally create that ripple effect of 1 to 25 people. Further to that, for every one person that dies by suicide, up to 60 to 90 people in their social circle are bereaved. They are grieving by that loss, because this may be someone's son, someone's daughter, someone's brother, someone's sister, someone's father, someone's nephew, someone's uncle. And this is a loss and a bereavement. But because society has stigmatized suicide, we're not giving them, the family, the dignity for them to grieve and mourn that death of that loved one. So again, we are actually creating a ripple effect of trauma in society. So we have a lot of unlearning to do to actually take away this, burden on suicide. And now coming to the personal level. On a personal level, should you know someone who is having thoughts of not wanting to leave, feeling overwhelmed, then the first thing that you need to do is actively listen. That's all. That's the recipe, that's the secret ingredient. You need to listen. You need to ask them to say, how can I be of help? How would you like me to help you? I'm here to listen. And if they're at risk to themselves, where they're actively thinking of carrying their act out, they have even mentioned it, and they're actually talking about it actively with you, and you feel uncomfortable, then take it upon yourself to actually take them for help. Link them with a mental health expert or mental health provider so that they can be guided accordingly. Okay, so again, on an interpersonal level, how will you know if a person is talking about wanting to die or wanting to kill themselves? Or if a person is talking about feeling empty or hopeless or having no reason to live? Or if a person is talking about feeling trapped, or feeling that there are literally no solutions to life? Or if a person is feeling unbearably emotional or physical pain, or they're giving away their important possessions, they're withdrawing from their friends or family, or they are now saying goodbye to you, and you find yourself asking to say, oh, why are they putting their things in order? And talking or thinking about death often. So for such individuals, be there, be present, and then be a listening ear. Do not give advice, do not give solutions, do not tell them what to do, but be there to listen to them, and then offer them guide through a mental health expert. Take them to a mental health care provider or nearest clinic or healthcare worker so that they can get the support that they need. So I believe these are ways that we can actually take it upon ourselves within our networks, within our communities, to actually create that system where individuals that have thoughts of not wanting to live can be open about it.
Oh, thank you. So the first thing we have to do is to unlearn. It's not a taboo. It's not a taboo, and people that commit suicide, they're not looking for attention, but they're actually dealing with things that are very big and beyond them. I think that's a big thing that everybody should take, and those are things we have to unlearn. So if the cup is full, like they say, you have to empty it first, and then you can actually help. We should be ready to listen. But most importantly, we should direct these people to specialized care, because they need to be seen by somebody who can actually help them through it. it's been a very good discussion. Maybe we can just answer a couple of questions in the chat. So one of the questions from the chat says, as an average person with no background in clinical psychiatry, what are the best ways to approach when a friend confides in you? Unless you want to add to that, I think this question was answered partly.
Yeah, so here's the thing. Look, I'll be honest with you, Teddy. I also, in my personal life, so this is my professional face that I'm showing you right now. I am also human. I have the same learnings and culture, being born and brought up here in Zambia. I have the same understanding about self-harm and suicide. I have been privileged to get the education to understand brain health better and now be an advocate for religious elders and cultures to understand. But it's a sensitive topic. So the first thing that you can do is, it's okay to feel guilty that I don't know how to help this friend of mine or this family member of mine who is having thoughts of not wanting to live. It's very normal to feel like that, because remember, it's a sensitive topic. But the one thing that we can all do is not sensationalize it, or let's not, push it away or say it will just disappear. Let's face it, let's create open spaces. And the first thing that you can actually do is saying, thank you for sharing this with me. How can I help you? How do you think I can help you? And I am here to listen to you. I may not have the right words. I may not have the solutions. I may not have the answers, but I am here for you. So let's do this together. This will take you a very long way. And this is something that you need to understand. Individuals may constantly repeat the same concerns over and over again. Don't give up hope and don't become irritable or overwhelmed by it, but communicate in the sense that listen. When you're communicating, you're listening. And when you're being there non-verbally as well. You don't have to always say something. Just being present in the person's life is enough. Making sure that, are they getting adequate sleep? Are they feeding themselves or eating themselves and not neglecting themselves? And how is otherwise their mood? If there is a change in any of these three things, then request them to say, please, I'm concerned for your health. Let me take you and accompany you to a healthcare expert, and let's see how best we can support you. This is how you, as a person who is coming from a limited clinical background or having knowledge about self-harm thoughts, can help another person.
Okay, thank you. So for those with family members who have committed suicide, what steps can be proactively taken to avoid going down the same path? So this could be a sibling, an aunt, a mother who's suffered the loss of someone from suicide. How can they themselves prevent them, avoid going down the same path?
One of the statistics that I shared earlier on was that because of the way suicide is perceived and the stigma and the stereotype that is associated with suicide, individuals that lose a loved one through suicide are not accorded the opportunity to grieve and bereave the loss of a loved one. So the first thing is actually to allow that family to process that death, to process that loved one, and to communicate that openly. The second thing is to actually get them support through therapy, for instance. Talk therapy goes a very long way to equally screen and assess them to say, are they equally feeling hopeless, helpless, or overwhelmed in any other way? If so, then they too can get the treatment and support that they need. The third thing is, because of losing a loved one to self-harm or suicide, it means they're at a higher risk of they themselves carrying the act out, which means they equally need the social support that I mentioned earlier on, to be there for them, to be present for them, and communicating to them to say, look, this is something that is severely overwhelming for you, and we are here for you. So these are certain, protective factors that friends and family can put in a family or a loved one's life for who has lost a close one to suicide.
Thank you. So for those that are watching from YouTube, please feel free to drop your question in the comment section. Feel free to drop your question in the comment section. So we've tackled two questions from the chat. I also just want to bring to your attention a comment from our YouTube platform. So there's There's a viewer whose comment is saying, based on Commander, yes, they still arrest them. To me, it is good because as susceptible individuals can easily be connected to mental health specialists for case management. Even if they have life to live, they have no right to harm themselves. What is your response to that, Dr. Dalal? Because it's a good point. When they're arrested, they can easily be connected to a mental health specialist like yourself. So that is a concern as well coming as to why maybe that is done. What's your response to that?
So here is a person who has self-harmed, and this is a traumatic brain concern. Let's look at it from a physical health perspective. Here is a person who has hurt themselves in a severe road traffic accident, and the first thing you do is you take them to the police station because you are saying that they are at risk to their life. So you've taken them to a road traffic accident, you've taken them to the police to report it before you actually bring them to a healthcare expert. Why should you take them to the police? Why not directly bring them to a healthcare provider so that they can be supported? And then from there, if you still feel that you want to link them to surveillance or care, you then trigger the justice system. This is where we get it wrong, because these are not people that are going to hurt other people in many times. These are people who are constantly hurting themselves. And for them, they need de-escalation support, de-escalation therapy that can only be done by experts. Because the way society perceives, if you're going to take them, no disrespect to the justice system or the police system, but these are the people that are in the police system are the same people that are found in the community. We have all these unlearnings to do in our society before we can actually say that, yes, this police system or the community system is safe enough for them to understand something as critical and sensitive as suicide. So my response to Kumwenda is that yes, I do agree that they need surveillance, they need support in that sense, but at the same time, we need to have protective caring factors when individuals are going through an emotional storm. Because many times when a person is going through an emotional storm, they need a caring person around them. They need to go through de-escalation support therapy with people who understand them and understand what they're going through, rather than people who are going to throw more problems or concerns at them. So please understand that they need support right there and then. They need treatment right there and then, because taking them directly to in the justice system may delay them the care that they need immediately. So please understand that it's a psychiatric emergency, and that needs psychiatric emergency care right there and then. Thank you.
Thank you very much, Dr. Dalal, for your comment on that. We really do appreciate. We have another question from the chat. What advice do you have for those who have lost loved ones to suicide? For those who are confided in, who thought they had helped, but their loved ones ended up ending their own life. So this is a scenario where somebody comes to you and confides in me and says, Teddy, I have a problem and I might kill myself. And I try to the best of my ability to help them. But then unfortunately, they still go ahead and commit suicide. What advice would you have for me if I was that person?
So this is it's not uncommon to have certain situations, as you've highlighted, to say what advice would you have for such people. They actually have to go through many types of support systems, and one of the things that we do is take them through therapy. And one of the ways that we take them through is a therapy method or module known as acceptance and commitment therapy, where we have them process the actual ordeal that they've gone through. Because look, many times we're talking about suicide from a perspective of understanding the person that wants to die or wants to not want to leave, or carries the act out. But we often forget the carers that are equally in this to support them. And many times carers lose out. They lose out a loved one to death, and they too need that support and understanding. I've had many situations where I've had individuals reach out to say, look, we did our very best, but I lost my son, I lost my nephew, I lost my husband, I lost my father, I lost my wife, and I tried my very best to support them. To these individuals, it's more about giving them the time to go through the stages of grief and supporting them through that, and equally telling them to say, look, it is not about just you going through this, but it's also about what is it that the other person who lost their life also went through and why they carried that act out. So it's more about acceptance and commitment to go on with life and get the grief and the bereavement and the grieving process through it, so that they're equally able to process through that loved one's life as well.
Thank you very much, Dr. Dalal. Then, we've mentioned that people that are having suicidal ideations or thoughts of suicide, people that are having what we're calling passive suicide, they need help. So maybe you can just help us to know. There's a question in the comment section saying, what do counseling programs look like? So when they come to the hospital, what do they expect? How many sessions do you normally run for? Is it a chronic problem like a drug problem that will keep recurring every now and then? Things are we expecting?
Okay, so oftentimes, as I mentioned, I don't want to trivialize this or sensationalize this by the example I'm about to give you, because many times other people misconceive it. But I would like to give people an example of emotions. And the emotion that I'd like to share is that of anger. When people feel angry, they often say things or do things, carry out acts such as harm others or break things, or they may insult others or say words that are not palatable to another person. But after a few minutes, that person's anger kind of dilutes down and they feel a bit better. And majority of the times, when the anger subsides, they often question themselves. Others often feel guilty to say, why did I say that? Why did I do that? Or why did I not wait before I could, carry that act or say that thing out? Oftentimes with self-harm or acts of self-harm, unless it's an underlying chronic condition, it's to distract from emotional pain, and it's in the moment to release tension and to feel something or express self or self-punish. And this is what people need to understand, that suicide is not always equal to mental illness. Suicide can also be equal to an acute certain emotional storm. And it doesn't mean that if one person is having thoughts of suicide or has had actions of suicide, self-harm, then they are always going to have those thoughts. Many youth and adolescents actually outgrow the symptoms of risks of suicide or self-harm. Then for mental illness, oftentimes, if the person does not get this help, which is for major depressive disorder or bipolar or schizophrenia or anxiety, then these are the individuals that may have a higher risk of carrying the act out, and they need continuous support and care and next of kin support. So in a nutshell, it's not always that once a person carries an act out of suicide, they will always carry that act out. It's more about supporting structure and identifying the underlying cause and helping them through that.
Oh, thank you very much, Dr. Dalal. We really do appreciate for taking the time to answer all those questions. I don't know if you have any, I can't see any more questions in the chat. Neither can I see any more questions from our YouTube platform at the moment.
Yes, so there is actually a question from, there's no name, but it says, are parasuicidal patients still arrested? If so, what is the offense they are charged with? And I answered this earlier on, but I'll reiterate to say, no, they're not charged anymore. Suicide is not something that people should shy away from to get help from. If an underlying cause is found, and if a mental health expert guides to say this is clearly because of an emotional storm or it is because of a mental illness, then this person will be supported for treatment and will not be taken to charge for it. So parasuicide is a notifiable case, but it is not something that is, such that after a person recovers or is discharged from a hospital, they will be taken to prison for that. No, that's not the case. However, it is a notifiable case because we want to make sure that in that person's life, we have identified a good support structure, and also we have identified a good care plan for them from a healthcare provider like myself, so that they do not actually put themselves at that risk again. So that is the whole idea why we notify to the law enforcement, and we should, because we want to make sure that the environment is supportive for the individual.
Thank you very much, Dr. Dalal. There's a question from our YouTube platform just recently posted. Are there any critical signs? Critical signs that may point to one having a mental breakdown that may eventually lead to one committing suicide. I think so for Trifonia, Kajimoto, we are not using the terms committing suicide anymore as we have learned, but rather death by suicide. So what critical signs point to one having mental breakdown that may lead to death by suicide? Dr. Dalal.
Okay, so as I said, warning signs of suicide include things like talking about wanting to die or wanting to kill themselves, talking about feeling empty or hopeless or having no reason to live, constantly saying that they feel unbearable pain and emotional and physical pain. They withdraw from family or friends. They start saying goodbye to friends. They start taking greater risks that could lead death, such as driving extremely fast and so on, talking or thinking about death often. And then serious warning signs can include things like making a plan or looking for ways to kill themselves, such as searching for lethal methods online or stockpiling pills or buying a gun, or talking about feeling great guilt or shame, or displaying extreme mood swings, suddenly changing from very sad, very calm or happy, and then using substances such as alcohol or drugs more often, acting anxious or agitated, also having a change in their mood or their sleep patterns, and having rage, revenge kind of communication. So these are certain serious signs that individuals can think of or look for individuals that may be at risk of self-harming. And this is something that I always tell people to say, even though I've mentioned all these things, it's not always that these things will be present. For other people, none of these signs will be present, and you may just find that they've actually carried the act out, and you will find something like a suicide note left behind to actually tell you the burden that they had and that they didn't share. So it's often neither here nor there, but the best way to help individuals is to have an open communication and an open line with one another, and just showing concern and care.
Thank you, Dr. Dalal. Dr. Dalal, there's something also that I've been thinking about. So generally we say that when patients are recovering from major depressive disorders, when they've been depressed for a long time, we put them on drugs, they start doing pretty well. When they start responding, when they have a bit of energy, that's the point where they are likely to commit suicide, because they actually have the energy to execute whatever plans they may have had. Because generally depression is a state of no energy. So the moment we give them those drugs that help them, they give them energy, then they're likely to commit suicide. Maybe what advice can you give to the caregivers of the patients? Because in most cases, when caring for these patients, you have the family around them. For the people at home, how can we help these people from succumbing to suicide on their road to getting well?
Yes, so that is also something that we really put in play as healthcare experts in this field of brain health and mental health, where we make sure that an individual who has major depressive disorder or any other mental health illness that can have a risk of suicide, we make sure there's a next of kin who is in their care plan. And as we're going through the treatment, we actually have a surveillance or support structure present in the person's life beyond the clinical reviews. And the guide that we often give the carers is that, look, we are giving this medication, but make sure that this person does not take the medication all at once, or please supervise the medication and support so that they take that medication. Always make sure that you're communicating with them, monitor how they, how in physical health we monitor, we tell family members to say, make sure you check their temperature, make sure if you have to check their blood pressure, make sure if you have to check their breathing pattern. So with in mental health and healthcare, the vitals that we often tell caregivers to look out for is make sure you check in on their mood, how are they feeling, make sure you check in on their sleep, are they sleeping well or are they sleeping excessively, and make sure you check in on their diet, are they eating well or not. So these are ways that individuals can check caregivers can check in, so that they don't have a risk incidence of suicide as they're recovering with the medication. Um, Teddy, there's another question in the chat that says, what do counseling programs look like? How many sessions do normally run for?
Yeah.
Is suicidal ideation a chronic problem? So with counseling, this is what we need to understand, that counseling, also known as talk therapy, is as effective as medication for conditions such as major depressive disorder or acute stress reactions. It has been shown in research that the brain actually changes and molds itself when talk therapy is done well, which is what we call psychotherapy. So sessions can range from different models. For instance, for pain, there's different medication like Panadol, Brufen, tramadol. There are different types of pain management medication. Similarly, psychotherapy, there are different types of therapy models. There is one called as cognitive behavioral therapy. Cognitive meaning thought processes, behavior meaning the actions that we carry out. So this is a type of therapy where we support individuals with their thought processes, mostly targeted at the negative thinking and how to support them to convert that negative thinking into neutral or positive or helpful thoughts. We don't call it positive, but helpful thought processes. Similarly, behaviors. Whenever a negative thought comes up, what behaviors do they correlate with and how can we revert that? So that's cognitive behavioral therapy. Sessions can last from anywhere from 8 weeks going up to 12 weeks or even 2 years. So this is just one type of therapy. Then the therapy that I mentioned earlier on, acceptance and commitment therapy, where an individual understands that this is what their life is and this is how they are feeling and how to commit towards that. So again, this type of therapy can equally take from anywhere from 12 sessions to 24 sessions, which may equate to 24 up to 24 weeks. Then we have many other types of therapies, such as group therapies or supportive therapies. All of these have different objectives, and when done by professional mental health experts, they yield positive results and actually transform individuals' life patterns. And in particular, brain actually is seen to improve, and serotonin levels and other neurotransmitters also improve. So to give you that perspective, I'm glad that this question comes out, because many people think that counseling is just counseling, but no, it's not. There is evidence-based treatment out there, which even in Zambia is present, and we need to reach out and get people the help that they need.
Thank you. We can take one last question from our YouTube platform. It says, how can I deal with continuous thoughts of suicide due to a traumatic experience or depression? Maybe you can handle that as well.
So for that one, I would actually advise, first step is please confide in someone that you trust and love and that can support you through your journey of recovery. So if you have any thoughts that are continuous, just know that you need a good support structure. If you happen to be that you don't have anyone good you trust or support, please reach out to a mental health expert. And that mental health expert should guide you through an assessment to see whether you have an underlying condition or underlying symptom pattern that you need support with. And they may prescribe medication together with therapy and see through to it that you get that support that you need. And I say this because even when you are prescribed therapy, it doesn't mean that that's the only therapist. If you don't feel comfortable with that particular therapist, you can always change that therapist, because in as much as talk therapy is good, it can also have side effects and complications. But when you're having a traumatic experience, you need a support structure in your life, not just your social life, your familial life, but also a mental health professional who can help you guide, overcome, and have a post-traumatic growth experience rather than you having a continuous post-traumatic stress experience. It is not easy. It is brain health and it takes time to heal. This is a journey. And you really need to have the courage, which you may not have in this moment, but muster up the courage to take that step, and it's a day at a time. So my guide to you would be, get, first of all, a good support structure in your personal life, and then also reach out for professional help. And I am hopeful that you will get the support that you deserve.
Thank you very much, Dr. Dalal, for helping us with that question as well. I'm sure that's something that we can do. Let's reach out to the people that we can confide in and let's get the help that we need. Do you have any closing remarks, Dr. Dalal? It's been a nice 1 hour with you, very enlightening. I personally have learned a lot of things about how I can manage my patients better. And I hope that everybody that signed in with us today also took something home that they can use to help themselves and also to help others.
Yes, Teddy, it's World Mental Health Day. I would like to wish everyone, including you and all the people out there, happy World Mental Health Day. And I want to say that we all have mental health. People think that mental health is, the severe form of mental illness. We all have mental health. And there's a difference between mental health and mental illness, and we need to learn and unlearn that. We need to guard our mental health. We need to support our mental health. We need to thrive with our mental health when we need to acknowledge our mental health. And to everyone listening in, thank you so much. And I hope to continue interacting with you through my various social media platforms. And to you, Teddy, and your team, well done. And thank you so much for your invitation. I truly appreciate it.
Well, we're very grateful, Dr. Dalal. Until next time, I'm sure we're looking forward to having you once again on our platform. There's a lot we can learn from you.
I would always welcome myself to such spaces where I can share my knowledge. Thank you so much.
Thank you very much. Have a beautiful evening and happy World Mental Health Day to you too, sir.
You too. Happy Mental Health Day. Bye.
Bye-bye.